Thank you, Erik. I think, yeah, my talk will tie in nicely with Lisa's because it also focuses really on personalization of treatment and also some issues that we're running into with the current conceptualization of PTSD. Indeed, I'm about to finish my PhD. I think I said that last year when I was here, but this time for real. How do I go to the next slide? Oh, here. Okay. So, how we usually conceptualize PTSD and also other forms of psychopathology is really based on a medical model of disease, which means that there is a cause for the symptoms, which is the disease, and this causes all of the different symptoms that constitute the disease. We can measure those symptoms, and we have a list of symptoms, and if you check enough of them, you have this disorder, and we can treat this disorder so the symptoms will go away. This unfortunately does not work very well for mental health disorders. It's already an oversimplification in many somatic disorders, but in mental health disorders, this really does not work very well. Even though this oversimplification has been necessary in the past, and it's also brought us a lot of evidence-based treatment, there's really a lot of people who don't respond very well to those evidence-based treatments, and we need to figure out how to better conceptualize disorder for these people and how to help them in a way that fits better to their situation. So at first I'm going to walk you through some of the problems that we're running into with the current conceptualization of mental health disorders, and I'm taking PTSD as the case study here, but most of this is really applicable to any type of mental health disorder. So the first problem, Lisa touched upon as well, there's huge heterogeneity within this diagnosis. Isaac Gallagher-Levy did a calculation of if you look at all the DSM-based criteria and you take all the possibilities that are in there theoretically, not all of them are clinically very likely, but if you take all of them, there's more than 600,000 ways in which you can have PTSD. So this is saying something about PTSD as a diagnostic category. We're putting this label on people so that we can facilitate communication about them. This person has PTSD, therefore we know what we're both talking about. But really, there are so many different ways to have it that this goal is really undermined by how it's conceptualized right now. Then also, there's, of course, a dichotomy made between cases and non-cases, even though there are many combinations of symptoms that don't adhere to the diagnostic label of PTSD, but can cause similar suffering, or even worse. So there's this dichotomy where we call some people healthy that are really not, and then this is kind of an oversimplification also of the reality of mental health. Then, of course, in DSM, there's kind of a hierarchization of symptoms, but also oftentimes in research, and also in diagnostic practice, we work with cutoff scores. So we ask questions, and all of them are scored on the same scale. So, for instance, are you avoiding certain thoughts from 0 to 4? Or do you have flashbacks from 0 to 4? And both of them can contribute 4 points to the total PTSD score. But do they really cause similar psychosocial distress? I think this is also not really connected to reality. And then another big problem is that in mental health disorders, comorbidity occurs more often than not. So we're carving up reality into diagnostic categories. Well, does a person really have 3 different disorders, or do they just have a connected system of psychosocial complaints. And then both in research but also in clinical practice, we have an over-reliance on cross-sectional measures. For instance, if you take a baseline measure, you typically take one cross-sectional measure of where someone's disorder is at. Or if you take an intake for treatment, it's usually a single measure. And thereby we assume that mental health symptoms are stable reflections of an underlying disorder. While in reality, we know that mental health symptoms are not stable at all. They can fluctuate quite a bit. Even during the time of day, this can be impacted, but also over longer periods, this can change quite a lot. And then another problem is that we often focus on the average patient. We're trying to synthesize knowledge about as many people as possible, make it generalizable. But then group level processes really do not necessarily translate to the individual. We're seeing that a lot of people just react very differently than the average. So this is calling for a new and kind of different approach. And I will walk you shortly through an alternative conceptualization of mental health. So what we just talked about is the common cause model. Do I have a pointer? Oh, yeah. Oh. Okay, so on the right, you can see the model that I just kind of explained, where in this case, the depression, the disorder in the middle is independently causing all the symptoms. And the alternative conceptualization that's being proposed here is that all these symptoms are connected in a system where they can cause and exacerbate each other. And therefore, even if the original cause, if there is any, of the disorder subsides, these symptoms are interconnected and can therefore maintain the system. I will show you what this looks like in the case of PTSD. I've made a simplified network. So of course, in the case of PTSD, the initial event is a traumatic stressor. But this does not explain why the symptoms may persist when the stressor is already gone. And this model may explain why these symptoms persist, because they get stuck in a self-perpetuating loop. So for instance, if you have a traumatic stressor and this causes you insomnia, this can have a lot of impact on other aspects of your life. And in this case, you can see that insomnia, for instance, will cause concentration problems, which will cause poor work performance, which will increase worrying, and which will then exacerbate insomnia, which means that insomnia is indirectly causing itself. And the system gets stuck in a loop, and the problems will persist even if the traumatic stressor is gone. And so I'm looking to make these type of networks based on real-world psychological data. And I'm doing that with a new statistical technique that I will take you through shortly. I will not bother you with the details about the statistical technique, but the most important thing to know about it is that it is a bivariate technique that looks at the longitudinal trajectory of different symptoms and compares how they behave over time. And the important thing about this technique is that it can stretch the time. So if you look on the left, you can see up top the symptom insomnia and below the symptom irritability. You can see that the fluctuations are very similar in shape. They just don't happen simultaneously. So if you take a technique where you're looking at a point-by-point comparison, we're looking at time 1, what insomnia is doing and what irritability is doing, and then at time 2, we're also comparing the two, you will miss that this pattern of fluctuation is so similar. And what this statistical technique that I'm using can do is really stretch the time so that you are comparing the time points that really belong together, even if they're not simultaneous. So we have applied this technique to longitudinal data of PTSD symptoms. As Erik mentioned, I was fortunate to spend some time with the lab of Professor Masanori Nagamine at the National Defense Medical College in Japan. And they have a very large data set derived from their personnel who have been deployed in response to the Great East Japan earthquake. So many of you will remember this as the Fukushima disaster from 2011. So what happened was there was the largest earthquake in Japan's recorded history. This reached a 9.1 on the Richter scale. So this is really huge. Japan has a lot of earthquakes, but this was unprecedented. And what happened was, catastrophically, this triggered a tsunami and a meltdown of the Fukushima nuclear reactor. So there was just immense destruction. A lot of people lost their lives or got injured. And most of the Japanese military was deployed in response to this disaster. And they have been really diligent in collecting yearly mental health surveys from their personnel. And I was fortunate enough to be able to look into this data and collaborate with the Japanese researchers in order to investigate the dynamics of symptoms in this data set. So using the technique that I talked about before, we made this symptom network. One of the measures that they collected yearly was the impact of event skill revised. So we looked at first at the structure of symptoms in more severe cases. So we selected people who scored above a threshold at the IESR to see what the structure would be like for them. And interestingly, we found, compared to the original subdivision of the IESR, so normally this is divided in intrusion symptoms, hyperarousal symptoms, and avoidance symptoms, we found a new cluster that was previously dispersed over the different scales. But these symptoms really cluster together, and we called them the dissociation cluster. They are a bit different from the dissociation subtype of PTSD as specified in the DSM-5, but that's because the IASR is based on DSM-4. And therefore, the DSM-5 dissociation items are not included in it. But these items are all pertaining to a lack of presence in the now, so a numbness of feelings, and then a increased presence in the moment of the traumatic event. So that's why we called it the dissociation cluster. So this is new, and this is important to remember for later. Then we looked at, we wanted to see if there's differences in network for different groups of people with different longitudinal outcomes. So first we looked at what are the longitudinal outcomes in this group. So for this we used the full data set of more than 55,000 soldiers who responded to these surveys. And we found 5 different trajectories longitudinally of symptom severity. And we took the 4 that had symptoms throughout the course of follow-up. Why did we do that? Because in the ones in the resilient cluster, which is luckily about half of the sample, so most of the people did not really develop any PTSD symptoms, but because they don't really experience any symptoms throughout the course of follow-up, and our statistical technique is based on variation, we cannot really make any meaningful conclusions from this one. So we took the 4 ones that have some symptoms throughout the course of follow-up, and we made directed networks I put these little squiggles next to it so you can see that there's two networks for which the overall symptoms go down. The late onset trajectory, the symptoms go up over time, so they are worsening. And there's a chronic network, so those people start high in symptoms and remain high in symptoms over time. At first glance, the first thing you can see is that there are fewer connections in the chronic network. And we interpret it to mean that there is fluctuation in this network in symptoms, but the fluctuation is more independent. So we can't find connections between the fluctuations between symptoms. And that is important because, for instance, if my network is very connected and I improve one of my symptoms, for instance, I improve my sleep quality, this might have an effect on the rest of the network because my network is connected. And we think that maybe that's why these people have a more chronic trajectory, because if they improve one symptom, this is not likely to lead to other improvements within the network. So we're finding here, this is a graph showing the network density. So a low network density or high distance means a low number of connections. And you can see that the chronic network is really an outlier in this. So we're thinking that low network density means the network is not very likely to change. So probably someone with low network density will also not change very quickly from healthy to a more disordered state, but also the other way around. They might have a harder time getting from a state of psychopathology back to a more healthy state. So this might have implications for predicting treatment efficacy. So back to these networks, you can see that there's two networks of recovery and one of symptom worsening, and we found that those two networks of recovery really look the same. And most of the arrows are pointing towards one symptom, which is an emotional reactivity to trauma reminders, so that is the symptom that changed last. And this is really, matches well with previous literature and also clinical practice. We can see that this is often a residual symptom of trauma, that people still get emotional reactions to reminders of the trauma, even though they don't have PTSD symptoms anymore. And then in the worsening PTSD, you can see that most of the arrows are going towards the orange symptoms, which are the dissociative symptoms. So this is a cluster that was previously identified by us in this previous paper. So this is a kind of a pattern that we otherwise may have missed if we didn't previously identify these clusters together. So using the dynamic time warping approach, we can also chart the order of symptom improvement and also symptom worsening. So we added the two groups with improving trajectories together because we also made this graph for them separately. It's really the same. So you can see that the first symptoms to improve in improving PTSD are the dissociative symptoms. And then all the way down to the emotional reactivity to trauma reminders, which we previously discussed as a well-known residual symptom of PTSD. And then in worsening PTSD, we can see that in this cohort, really avoidance symptoms were some of the first that would worsen, which means these could be early warning signs in this group. Or also, if you do an intervention on these avoidance symptoms, there is a chance that this effect might cascade down through the network. Of course, we cannot say that avoidance here is causal on the basis of these data and this technique, but there is because they occur so early in the worsening PTSD, there is a chance that avoidance-based or approach coping-based interventions would really make a difference here. And you can see that the dissociative symptoms that we identified as a cluster really tend to occur late in worsening PTSD. And then, of course, what I've shown you so far is really still not transdiagnostic. So what I told you at the start of this talk is that one of the problems is that we have so much comorbidity. The research I've shown you so far is still, of course, only geared towards the IESR symptoms of PTSD. And I think future research should really adopt more transdiagnostic approaches. Of course, many of the longitudinal and cohort data sets that we have right now are really rooted in DSM thinking, so in this categorization. And I think it would be nice and very, I think it would be good to move towards more transdiagnostic approaches, and I will give you an example of how to do this, and also how to do this for an individual patient. Of course, all the research I've shown you so far is geared towards the group level still. And as we talked about before, we need to move towards more ideographic approaches. So I'll show you how to do that right now. So one of the things you can do is a ecological momentary assessment module. This is a way of really capturing ecologically valid data, so people don't really come into the office or hospital to do a data collection. You can do it via a person's smartphone. You can do it multiple times a day. It's generally at low cost to the individual. And you can just send them a list of questions, ask them to rate some things, and you can then gather a lot of data for one specific individual to make a really nuanced and detailed network. And we did this on the basis of 20 mood items that were delivered to patients suffering from depressive and anxiety disorders. So this is a mood item EMA module that was delivered over the course of 2 weeks for 5 times a day. And you can see that, again, the mood states are represented by the circles. And the red circles are more negative mood states. The green circles are more positive mood states. And the arrows between them really show you the connections between them over time. So the green arrows mean a positive connection. So, for instance, if this person felt enthusiastic at a time point, at the next time point, they were a lot more likely to feel satisfied as well. And then the red arrows are a negative connection. So you can see really here for this person, the note tired has a really negative, I want to say effect, but really we have to take causality with a grain of salt here. But when this person is tired at one time point, at the next time point, they are really less likely to feel energetic, to feel enthusiastic, or to feel any other sort of positive emotions. So that means that this can generate hypotheses about where to start for this patient. And I think that is really important as kind of an addition to the current way of looking at psychopathology, because these networks in these mobile apps, they can be made during the waiting list period as a preparation for treatment. And they can give people easy insight in how their psychopathology works for them. and might give them some feelings of self-efficacy. And there's really, we right now only included mood states into this network, but there's anything that is measured as a time series can be included into this network. It doesn't even have to be measured at the same rate. So anything that is measured as a time series can go into this network. And you can really give a very complete picture of the individual's mental health and what kind of factors could influence this for the person. So I think adopting these kind of networks into practice would not be very difficult. It could be quite cheap as well, and I think it will represent a nice complement to what we are currently already doing that is really tailored towards personalized medicine. Thank you very much.